Hi everybody, my name is Audrey Deering and I am a Principal Genetic Counsellor here at Fertility. I'm just going to wait a few more moments just to get some more people to join, but today I'm going to be talking to you all about genetics and fertility treatment, and I hope I'll be able to answer some of your questions. And I'm just going to give it another little minute or two and then we'll go ahead and get started. Okay. So if you've just joined, my name is Audrey Deering. I'm a genetic counsellor here at Fertility. Today I'm going to be talking to you about a genetics and fertility treatment. So I'll just kind of start by going through what genetics is, what I mean by that, and kind of how it can apply to things that might be of interest to you. So I'm sure, as many of you probably know, every gene in our body tells us how to grow and to develop. So, we've got genes for hair color, we've got genes for eye color. It can even change how our personality works. And for a lot of people, family planning can be a really exciting time because you might be wanting to see what genes are passed on. But for other families, people might be a little bit worried about what genes are being passed on, or they might be a little bit concerned about whether there's something genetic happening that's preventing them from starting a family altogether. There are genetic reasons why some people might struggle to fall pregnant, or genetic reasons why those pregnancies unfortunately aren't continuing to term. So what I'm hoping to do today is to talk to you a little bit about how genetics can impact people's ability to get pregnant, stay pregnant, and what might happen to those babies who are born, and again, how it might apply to your fertility journey. So understandably, if you're struggling to conceive, you might be wondering if there's an explanation or a reason why you've unfortunately had to experience that. And we can kind of think about lots of different reasons, but I'll be talking to you about the genes or the genetic reasons why somebody might be struggling with reduced fertility. There are a couple things that we can think about when an egg provider, for example, is struggling to fall pregnant or to stay pregnant. So, for example, if somebody has reduced ovarian reserve, or they might be going through premature menopause, especially under the age of 30, that would be quite unusual. And that would make us wonder if there's a genetic reason why unfortunately that's been happening. We also might think about genetics if somebody has unfortunately experienced 3 or more pregnancy losses. So that could be a chemical pregnancy or a miscarriage. For sperm providers, sometimes we think about genetic reasons if the sperm provider has something called azoospermia, or no sperm at all in the ejaculate, or a reduced sperm count. So those would be the kinds of things that we'd be starting to wonder if there was something different about those genes that was causing those types of fertility problems. So if somebody was having something like that, one of the first line genetic tests that we would offer is something called a karyotype. So how that works is it's a blood test, and the lab will look down the microscope at the blood and they look at the size and the shapes of the chromosomes. So most people have 23 pairs of chromosomes, and most people inherit one set from the sperm that was used to make them and one set from the egg. But what we actually find is that sometimes some people have differently shaped chromosomes. So sometimes there's 2 chromosomes stuck together. Sometimes there's a little piece of 2 chromosomes have broken and swapped places. That doesn't cause that person any health problems. So there'd actually be no way of us knowing that somebody had these chromosome rearrangements without doing a genetic test. But what we do know is that people who do have those types of things can unfortunately make it a little bit more likely to pass on too many or too few chromosomes to the next generation. If unfortunately that does happen, we might see things like pregnancy loss or miscarriage, recurrent implantation failure. So by that I mean embryo transfers that unfortunately are not successful or don't take as a pregnancy. And again, people taking longer to get pregnant than they would hope, even if they had otherwise average fertility. So obviously it could be really upsetting if we do find something like that. There are things that we can do. So if we find a change to the shape or the number of the chromosomes, we can think about doing a type of fertility testing that has an extra step where we do a genetic test on the embryos to see how many chromosomes are there. And then we would only use the chromosomes that have inherited the correct or average number, and use those embryos for the rest of your treatment. So that's a type of fertility treatment called pre-implantation genetic testing structural rearrangements, quite a mouthful. There is NHS funding available to some couples in England. So if we did find something like that on a fertility test or blood test for you, we could talk to you about if we think that you would be likely to be eligible for NHS funding and try to put you in touch with the people who would arrange that for you. Of course, it's not only important how those chromosomes are shaped, but also how they're spelled. So you can think of a chromosome as made up of a bunch of DNA, and DNA is almost like a string of letters. And again, it matters how much of that string there is, but also the shape and the spelling of those letters. So some people are born with changes in those letters that can predispose them to having a baby who might be unwell. So we can also offer them a similar type of genetic test where we also look at the spelling of those genes, which is called pre-implantation genetic testing monogenic, or PGTM. So the purpose of doing PGTM would be to avoid passing on a specific genetic condition that we know about in a family onto the next generation. To be able to do that test, we obviously need to know what we're looking for. So it's not a screening tool. It would be for families who knew that there was definitely a genetic condition in the family. We're really proud of our PGTM service. So we think that we're a really quick and efficient and nice service. And if you felt like there's something in your family that you were worried about that could be hereditary, we can chat to you about whether we think that would be a good option for you. But going back to people who maybe don't have a family history of anything that they're aware of, and again, they're thinking about things like recurrent pregnancy loss or miscarriage. We at Care have a test called CareUnity, which is a test that we've developed. And what that does is it looks at, again, how one of those genes are spelled. So this is a gene on the 4th chromosome, so we call it C4. And then the exact spelling change is called M2. So another way of spelling, they're saying this is C4M2. Now, we know that people who carry this specific gene spelling change, it can affect the way that their blood clots. And the reason why that's important for fertility is that unfortunately those blood clots can form in the placenta or in the womb, which sadly can make it less likely that the pregnancy will take, or that, again, that pregnancy will continue to term. So by doing a blood test, if we found that somebody had the C4M2 change, we could give them blood thinners just before they have their embryo transfer. And touch wood, if they fell pregnant, we would continue to give them that blood thinner until they're around 12 weeks pregnant. So that would be the case if a person, the female partner, was found to have the C4M2 variant, but also we know that the sperm provider would be important as well. So we know that the embryo would be half from the sperm provider. So if he was a carrier of that variant, there would still be a chance that the placenta could clot based on that. So again, we would give those blood thinners in that circumstance as well. Another screening test that is relevant for more people in the general population is similar to what I've chatted about before. So that's a type of test where we screen the number of chromosomes. But instead of doing that because somebody has an inherited predisposition to passing on unusually shaped or numbered chromosomes, we do know that as we get older, the eggs and the sperm are not quite as good at putting the correct amount of chromosomes into the egg or the sperm when they're making them. So there's a type of genetic test that we can do on embryos before implantation called PGTA, where the A stands for aneuploidy. Again, we do know that age is important, unfortunately, when it comes to how many chromosomes are put inside each egg, and to a lesser extent the sperm as well. So for example, for a egg provider who is under the age of 35, we might expect that 55 to 60% of the eggs would have the average or correct amount of chromosomes in there. Whereas if an egg provider was maybe over the age of 42, that would be around 15%. So by doing that screening on the embryos, what we'd be hoping to achieve is to pick which embryos are the best chances of taking as a healthy pregnancy. So the lowest chances of undergoing miscarriage from those embryos. And we'd be prioritizing those ones for treatment. So there's 3 different types of results that one can get from that type of PGTA testing. So one is called euploid, and that's when there's 2 copies of each chromosome in every single cell that we look at. And again, we know that those have the highest chances of taking as a healthy pregnancy, and we'd recommend using those ones first. Unfortunately, if an embryo inherited too many or too few chromosomes in every single cell, we would call that aneuploid. I'm sorry to say that aneuploid embryos have a very low chance of taking as a healthy pregnancy. So we would not recommend transferring aneuploid embryos. So where there's a little bit of a grey area is when the same embryo has a mixture of cells that are euploid and cells that are aneuploid. So that is called a mosaic embryo. And I think we got a question about this beforehand, so I'll go into a little bit of detail about mosaic embryos. So embryos are really amazing things, and actually it is possible that a mosaic embryo could kind of fix itself as it continues to develop. So as long as there's some healthy cells in the embryo, it's possible that the embryo can just keep growing those healthy cells and kind of turn itself euploid as it continues to develop. It doesn't always happen, but it is possible. So the chances of it taking as a healthy pregnancy depend a little bit on how many cells are involved and the number of chromosomes that are involved and what those chromosomes are. So for families who find themselves with mosaic embryos, which does happen, what we would do is we would offer you a bespoke appointment where we would talk to you about your specific results. We would talk to you about the chances of it taking as a healthy pregnancy and the chances of the pregnancy continuing but not being healthy, so being affected by a genetic condition. And we really help support you in deciding if it's an embryo that you felt prepared to use, or if you felt like for you that those statistics didn't sound very reassuring and you'd rather not use it. So basically we would just really support you in sharing that decision making and helping you make a decision that was best for your family. So I know I've talked a lot about, things that people are born with or that they don't really have any control over. A lot of people ask me if there's anything differently that they can do in their lifestyle to help affect the genetic results of embryos. I really wish I could say that there was, but maybe fortunately or unfortunately, our genetics are kind of happening by chance, and there's nothing too specific that we can recommend to affect the genetic test results for the next generation. We would just say everything else we'd probably say to any other couple. So, think about taking folic acid before conception, enjoy moderate exercise, don't smoke, try not to drink to excess, probably all the things that we know about that we should be doing anyway. I really hoped that today was interesting and that you feel like you might have learned something. If I've said anything that you feel like, oh, actually that might apply to me, I think I might want to know a little bit more about this, you're more than welcome to ask to get in touch with us here at Fertility or to ask your healthcare professionals for a referral as well. And we'd be more than happy to take a really detailed look at your personal history, your medical history and your family history to see if there's anything jumping out at us about your genetics that we think should be investigated or that we think would be good for you guys in your unique circumstances. I've just seen that we have some questions come up, so I'll just have a little look. So we have a great question about cystic fibrosis. So cystic fibrosis is a genetic condition where people have changes to their lungs and digestion. So somebody is asking if one person is a carrier and the other isn't, can they pass it on? That's a great question. So a gene is like a physical thing. So if you don't physically have a gene change, you cannot physically pass it on. And for cystic fibrosis specifically, both the sperm and the egg provider need to be carriers to have a chance of having a baby with the genetic condition. So I'm happy to say that if at least one person in the partnership is not a carrier, then they can't, or there's a very, very, very low chance of having a child who has the illness cystic fibrosis. Now, they could be a healthy carrier, same as the other parent. Being a carrier doesn't usually cause any significant health problems. Most people won't know that they're a carrier, and again, unless they have a specific blood test to look for it. So we would say that, they could just report any concerns to their GP, same as anybody else. But the odds are that they would be healthy and not affected by cystic fibrosis. Every baby in the UK that's born is offered screening for cystic fibrosis at birth as part of the heel prick test. Another name for that is the newborn screening program. So yeah, I think hopefully that's a bit reassuring. Somebody else is asking a really great question about low sperm mobility. So the amount and the shape are fine, just a bit slow, and they've been taking supplements and exercise for the past 3 months, which is a really positive sign, as I said. In terms of the genetic side of things, there's probably not a genetic explanation for that I can easily think of. So the genetic effects on sperm that I'm more familiar with would be more to do with sperm count and the shape of the sperm. So if it's low mobility, it just might unfortunately be one of those things, but it sounds like you're doing great stuff. So, keep exercising in moderation, good diet, all those types of things are really, really helpful. Try to avoid extra heat to the lap. So sometimes people work with their laptops on their lap, so try to avoid things like that. That would be all a positive thing. And I guess there are fertility treatments where if we felt like it was required, we could inject one sperm straight into the egg, for example, or maybe push the egg in a petri dish full of sperm and try to encourage it to fertilize. So there's definitely treatment options there. I don't see that anybody else has sent in any more questions. I'll just give it another minute or two in case anybody has anything else that they wanted to ask about genetics and fertility treatment. Okay, I don't see anybody else typing or putting any more questions in. So I guess just to kind of summarize, obviously, there's lots of things that we talked about today. If you felt like, again, you were worried about your family history, or if you thought that you maybe have experienced recurrent implantation failure or pregnancy losses, or if there's somebody that has something that you were told was hereditary when you were younger and you wanted to learn more, you're more than welcome to let us know and we can see how we can help. You are also very welcome to send us an email if you had any further questions. So our email address is PGT, so P for Panda, G for Gamma, T for Tango, and then admin@carefertility.com, and we can help. Just need one more or two more questions. So there are genetic tests on the NHS. It depends a little bit on the chances that we're going to find something. So if you felt like you wanted to explore whether genetic testing would be possible on the NHS, you could ask your GP to refer you to your regional NHS genetics centre. And then if you were speaking to the genetics team and they recommended fertility treatment for genetic reasons, you could ask them to refer you specifically to CareFertility, and we can try to take things from there. I saw some questions about the cost. I know we talked about a few different types of genetic testing, so if you wanted to maybe email in to mention the type of genetic testing that you were interested in, and we can give you the costing for that as well. Why does IVF fail? That's such a good question. There's so many reasons. So I'm just going to type my email into the chat like somebody asked. So there's so many reasons. Some of them are genetic, many of them are not. We do know that there are lots of genetic reasons why that might not be successful. Most of the time it would be because an embryo inherited too many or not enough chromosomes, which would be picked up by the fertility treatment that I mentioned called PGTA. Sometimes we just don't know why, I'm sorry to say. So sometimes everything seems to be absolutely perfect and we just aren't getting anywhere. Sometimes it can be because of clotting, which is, again, when I mentioned the CareUnity, that can be a helpful thing to see if you need blood thinners during pregnancy or before pregnancy to help increase the chances of the pregnancy taking. So again, if you're concerned that you're experiencing reduced fertility or infertility, please just do get in touch and we can do some investigations to try to see if we can get to the bottom of things. But I'm sorry to say we don't always manage to get to the bottom of things, but obviously there's lots that we can do to try. I don't know a lot about sperm fragmentation, I'm afraid, but what I'll try to do is try to get somebody to get in touch to respond about that. For dual stimulation, so that's when we have 2 cycles in a row, there is success in doing that. Obviously, it's a lot to go through for some people. Other people think that, it might increase the numbers of embryos we might get, and that could be helpful. Our success rate is really variable depending on the type of treatment that we're talking about. So I can tell you that if we do PGTA, for example, which is when we count the number of chromosomes in an embryo, if an embryo has the average number of chromosomes, which we call euploid, we would hope that about 52% of those embryos would take as an ongoing pregnancy. So the word ongoing is important. So ongoing means pregnant on an ultrasound scan, which is usually done around 8 to 12 weeks, not just a positive pregnancy test. The success rate for mosaic embryos is a little bit different, and again we would talk to you about that based on your unique genetic test results. Okay, I'll just wait another minute or two in case any other questions trickle in, and hopefully you've seen that put our email address in the chat, so if you had any genetic questions about fertility services here, you're welcome to email in. And again, if you had any non-genetic questions, you can contact me as well, and I can try to forward them on to the right people. So ask you about how much IVF treatment is for people over 35. So again, it depends a little bit on your unique circumstances about what type of treatment we think would be most helpful. So if you wanted to get in touch, we could talk to you about your unique circumstances and try to give you a cost estimate. And we try to be really transparent about those types of things up front, so we try to give you a price and stick with it rather than tacking things on halfway through. Okay, don't see any more questions. Okay, another clinic said that they don't do PGTA because an egg is very fragile and the polar body was really big. I'm really sorry to hear that. So when we do PGTA testing, how it works is we wait until an embryo is about 5 or 6 days old. At that point, the embryo is probably a couple hundred cells large. We do it at a day 5 biopsy because we feel like that's more representative of the embryo at large. And we safely remove some cells. We try to aim for around 5 to 10. So when we remove the cells, we know that there is a small chance, but a non-zero chance, that it could damage the embryo. So we would only recommend doing that biopsy if we feel like the embryo would be able to survive it. So that would be an embryo with, a decent, what we call, morphology. So if it looked robust down the microscope. It also takes around 3 or 4 weeks for the genetic test result to come back. So the embryos are frozen while we wait for those results to come back. So we also need to be assured that we think that the embryo is probably healthy enough to survive that freezing. So unfortunately, if sometimes the embryo looks very fragile, we would unfortunately say it was not probably going to survive the biopsy and freeze, and wouldn't recommend doing that. So I'm sorry to hear that was your experience. And I think I answered the question before. We do day 5 biopsies, again, because we feel like it's more representative of the embryo at large, and we think it has a lower misdiagnosis rate. I'm really sorry, I don't know anything about prolactin and IVF, but again, we can try to get somebody to get back to you about that. Anybody else have any thoughts or questions about the genetic side of fertility treatment? Again, I've said it a couple of times, but I'll just mention it again. I put my email in the chat. If you had any genetic questions about fertility treatment, I can do my best to answer, and if I don't know, I can try to find a person who does. And I guess just to say one more time that obviously I know we've talked about some sensitive topics. We've talked about pregnancy losses and failed implantations. So if you feel like you wanted anything I've said kind of relates to your personal experiences, you can ask your healthcare professional, or you can refer yourself to us. Another really great question: how come sometimes you can have healthy embryos but no success? So great question. Again, sometimes we're able to find out why embryos do not result in healthy pregnancy. sometimes embryos can look fantastic down a microscope and can have great morphology or grading. But if we did do that PGTA test, we might find that they have an unusual number of chromosomes, and therefore the chances of that taking as a healthy pregnancy are as low as they can get. So, sometimes we think that by doing those testing, we can try to give an extra layer to what we are defining as a healthy embryo or not. Of course, again, there's the genetics of the embryo is one side of it. Sometimes it's due to the genetics of a person, which is again where we come across those things about the clotting that I mentioned. Sometimes the immune response of the womb can make an important effect. And again, sometimes we don't find an explanation. So we can try to look at your cycle as a whole to see if there's anything that we might want to do differently. So PGT stands for pre-implantation genetic testing. So it's a type of genetic testing in an embryo when it's about 5 or 6 days old. I've just come across a question here. So somebody says that their consultant advised them against PGTA, which is again doing that genetic test where we're counting the number of embryos, because some can come back bad, but fixing the uterus. So that's a really great concern and question. So the PGTA technology has changed a lot in the past 5 years. And maybe 5 years ago, we would classify only 2 different types of results, where we would say they're either good or bad, and there was no grey area. Nowadays, we know a lot more nuance, and we can tell in a lot more detail the kind of grey area. And previously, maybe 5 years ago, an embryo that we would have called bad, now we're saying is grey area, which we again call mosaic. And we do know a lot more about mosaics now than we did maybe 5 years ago. So we know that we can kind of see that some mosaics actually do have reproductive potential and can take as a healthy pregnancy. So I think just the technology has gotten a lot better, and there's a lot more nuance now, and we're able to kind of support people making those decisions if they feel like they want to take a chance on that great embryo or not. Again, there's a lot more evidence now than there used to be, and we still think that an aneuploid embryo or one with an unusual number of chromosomes, the chances of that taking as an ongoing pregnancy are negligible. So we're very confident that that the genetic test results can be a pretty good predictor of what might happen in the future. And I'm really sorry to hear about your pregnancy loss and your implantation failure. Thank you for sharing that with me. Again, I'll just leave another little minute or two if anybody else had any thoughts or questions. So again, just to tell you a little bit who I am, if you joined a little bit late, my name is Audrey and I'm a Principal Genetic Counsellor here at Fertility. So I'd be the one who was looking after you if you had mosaic results, if you were thinking about pre-implantation genetic testing for hereditary reason, things like that. So just got another comment here. So somebody said that they had a low AMH or ovarian reserve and follicle count, and it could be taking chances away that things would be okay. I can see why that's a concern. I think different healthcare professionals feel differently about PGTA. Some people, again, might be concerned about the chances of us saying that you should not use an embryo and then it could take as a healthy pregnancy. But again, I think the way of saying it is a predictive value. The predictive value of this test is quite high. So, I can't, I imagine you might agree that the possibility of going through a pregnancy test that doesn't continue to term isn't necessarily a positive experience. So it's true that, let's say you only had 5 eggs and they only turned into 2 embryos. If we did PGTA testing, we might tell you that neither of those embryos were worth transferring, which obviously is a very devastating thing to hear. But it's not going to change, I guess, the outcome. So whether you've had those 2 transfers and they don't take as a healthy live-born baby, or you don't have the transfers, it's the same, I guess, reproductive outcome. But again, different healthcare professionals feel differently about it. If you wanted to have a further chat about the pros and cons, we can certainly do that with you. So somebody was asking about implantation failure. So Sometimes we don't know why implantation failure happens. There are tests that we can do to try to see if there's a likely explanation. So that can be doing blood tests for the partners to look for things like maybe their immune system is reducing the chances of the pregnancy taking. Maybe there's a clotting problem where there's blood clots forming in the placenta that are reducing the chances of the pregnancy lasting. But mostly what I've talked about here today is genetic reasons. So that might be, again, one of the parents has a change to the shape of their chromosomes that makes it less likely that their embryos will have the average or correct number of chromosomes, so wouldn't take as an ongoing healthy pregnancy. And again, there's that screening test that we can do that I've been chatting about, where we count the number of chromosomes and then only consider transferring embryos that have at least some healthy cells or some cells that have the correct or average number of chromosomes. And that what we're doing is we're hoping that that will reduce the chances of a pregnancy not taking or recurrent implantation failure. So somebody's asking if shouldn't bloods be taken before the first implantation to reduce the chances of it failing in the first place? Great question. So it's certainly a possibility. That's certainly something we can do. Thankfully, a lot of the things that I've talked about are relatively uncommon. So for example, for translocations or chromosome shape abnormalities, maybe around 1 in 300 to 1 in 500 people in the UK carry something like that. So some people who were planning a family would probably want to do a blood test to see if there was any reason to believe that they might experience something like that. Other people might feel like the chances of actually finding something are low and they would be happy to go ahead with treatment without doing a blood test. Just a really personal thing, different people are different. Some people want all the information they can get. Some people kind of want to take things one step at a time. So we can certainly talk to you about doing those blood tests, but it's your decision if you wanted to have it or not. And I'm sorry to see that somebody feels like they hadn't had some of these things offered to them before they've had fertility treatment. I guess, without knowing your unique circumstances, it's difficult to say why it wasn't mentioned. But again, you're welcome to get in touch or to refer yourself or to ask a healthcare professional to refer you, and we can try to go through your history and see if it's something that we would think that might be helpful in the future. Okay, so for anybody just joining, I'm a genetic counsellor here at Fertility. I've been talking to the group about their options for genetic testing, either before conception or during an IVF cycle. Somebody's asking if we would recommend the testing after having a miscarriage. I'm sorry to hear that. I hope that that's not your experience, and if it is, I'm sorry to hear that. It is an option. So the NHS typically will recommend it if you've had 3 pregnancy losses or miscarriages or more. It's entirely up to you if you wanted to have it on a self-funded basis. If you've experienced 1 miscarriage, that's certainly something we can discuss with you. Again, sometimes people can find it helpful because it might provide an explanation or a likely explanation for their miscarriage or pregnancy loss. Other people, again, would prefer to have less information. It's just really a personal decision, and that's something that we would hopefully try to help you with, is again by talking to you about the pros and cons of that test, so what it can do, what it can't do, and talking to you about what kind of person you are, if you find you would feel that very helpful or not so much, to help you decide if it's something you wanted to go forward with. So I guess the short answer is yes, we would be able to offer it on a self-funded basis if you've had a pregnancy loss, and it's commonly available on the NHS if you've had 3 pregnancy losses or more. So I've again been chatting to you guys about the NHS won't help anybody with an AMH under 5.4. I'm sorry to hear that. Again, it's not always an option for everybody, but you're welcome to get in touch about the costings for self-funded treatment. And again, we can talk to you about the pros and cons of that with your unique fertility results in mind, but I appreciate it's not necessarily an option for everybody. So if you're just joining, my name is Audrey Deering. I'm a genetic counsellor here at Fertility, and I've just been chatting about genetic types of in vitro fertilization or IVF or fertility treatment. So whether that's genetic testing before conception or genetic testing during a fertility treatment cycle, so talked about some of the tests that we can do on embryos. So for example, PGTA, where we count the number of chromosomes in an embryo, or PGTM, where we look for a specific genetic condition in an embryo that we know is in the family. I've also chatted about something called a karyotype, which is when we do a blood test to look at the shapes and the numbers of chromosomes. And we've chatted about a test called CareUnity, which looks at how the blood clots, in case there's a clotting reason why we think these pregnancies aren't continuing to term. I'll just give another little moment or two, just in case anybody has any other questions. Do CARE support women who have natural killer cells? Yes. So there are some different types of things that we can think about. If somebody has an immune system that is possibly resulting in those pregnancies being less likely to take or to continue. So we have worked with people in that situation before, and we can chat to you about what, if anything, we would recommend doing differently in a frozen embryo replacement cycle, or before we put an embryo back into the womb, if there's any medications that we would recommend to support that pregnancy, hopefully sticking around. Again, I'll just give it a minute or two just before I sign off. I know it's almost dinner time. People are probably thinking about their next steps. Okay, you're welcome. It was a pleasure to speak to you all. I wish you all lots of care and luck on your journey. I hate the word luck, but I'm going to say it anyway. Again, my name is Audrey Deering at Care Fertility. So I've shared my email address in this chat, so I'll just do it one last time. And then if anybody had a feeling like anything that I've said to them really applied to them, and they wanted to know a little bit more about the genetic options that are available here at Care Fertility, you're more than welcome to let me know. And I will try to do my best to answer your questions, or if I don't know, I will find a person who does. All right, it was a pleasure to speak to you all. I hope you have a lovely evening and afternoon, and take care.